Hello everyone, thanks for joining in virtually today during this kind of crazy time that we're all in. So we're going to talk about delivering safe and effective transitions of care as part of your boot camp to get ready for your intern year. So let's get started. So imagine this. You're sitting there peacefully minding your own business on your first day as an intern, and all of a sudden you get a page. You look down at your pager and it says, "Are you covering for Mr. Smith in S932?" Your first thought is, no, that's not me. I'm a medical student. They need to page the right person. But then you realize, oh no, that is me. I am covering for Mr. Smith. So you say it, and the response on the other end is, well, he's unresponsive. You better come assess him. What goes through your mind right now? Do you look a little something like this guy here on the right side of the slide? I know I sure did when I first got my cross-cover call. What do you do? And importantly, was the information that you needed to know about that patient conveyed to you during the checkout that you received from your colleague before they left? How good was that handoff? That's going to determine on how prepared you are when you go in to see Mr. Smith. So here's what we're going to talk about over the rest of this lecture. We're going to say, how important are effective handoffs? How did handoff processes get developed? And how should you give effective handoffs? What are pearls to do it well? And what are some pitfalls that you can avoid? So why do we need handoffs? Well, simply put, because we allow interns to go home each day, and we don't make them stay in the hospital 24 hours a day. If we did, you would not need the handoff. You could just admit the patient, take care of them during their whole hospital stay. Thankfully, we have work duty hours. And so after you admit the patient, you're taking care of them, you're going to go home. And while you're gone, someone else needs to know how to take care of that patient. They need to know what you've learned that's important about that patient's care while you're gone. So when you get back, that patient is safe and sound and you can resume their care. So are handoffs really important? So when we look at sentinel events, and sentinel events are events that happen in the hospital, bad things that we do a root cause analysis and we say, I wonder if this could have been avoided. We see that 70% of those are due to an error in communication, and 50% of those errors in communications are actually due to a failure during handoff. So we know that handoffs are really important, and if we don't do them well, bad things can happen to our patients. Handoffs are really a transfer of responsibility. It is saying, look, now while I'm gone, you're taking care of this patient, but I need to prepare you for what you need to know while I'm gone. But they can also be an opportunity to learn. So if you get a patient checked out to you that's a diagnosis that you're not familiar with, or this patient has a really cool physical exam finding, you can go introduce yourself to that patient as the doctor covering for the evening, and you can do a physical exam on them. You can check in with them. You can learn about them. So not only are they a transfer of responsibility, but they can be an opportunity to learn as well. So how often do handoffs occur? Well, the average patient will be handed off 15 times during a 5-day hospitalization. So their care is handed off over and over again. And if you think of the average intern, you're going to hand off about 300 times each month. So in 1 month, you're going to do this process 300 times. So what's the goal of a good handoff? How do you know if you did a handoff and it went poorly? Well, when you get into the hospital the next morning, your colleague may look something like this. So this is Adam Sandler from The Wedding Singer, and he's saying, once again, things that could have been brought to my attention yesterday. So we don't want you to get that in the morning. We want you to get the response from your colleague, thanks for preparing me. I knew everything I needed to about your patients. So now we're going to watch a short video, and this is an example of a handoff gone wrong.
Oh my God, that family meeting went longer than I thought. And I have dinner plans. I have got to get out of here. Okay, I just need to update my sign out with this one last piece. Okay, let's try to print this. Oh my God, why is the printer out of paper? Why am I the only one that ever replaces this? I mean, they want us to sign out, but they make it so hard. You know, like, well, this is crazy. I'm just gonna have to use yesterday's sign out. Okay, oh my God, my pager's going off again. Where's Jeannie? I gotta go find her.
Come in.
Hey, Jeannie.
Hey, Benny. Hey,
How
what's up?
are you?
Pretty good. Hey, can you time me real fast?
Oh, okay, sure. You know what? I gotta get out of here. I'm
Okay.
in kind of a rush.
All right.
And
Can you get my hair behind my ear?
you know what?
Seriously,
you know what?
just
There's
put it behind my
15
ear.
patients.
Okay.
And you know, there's Mrs. H, and oh my God, she's really sick, and she has
Can
like
you get my
diabetes and
Can you get my
hypertension.
pager off my
and
belt?
she's- Oh,
Can you get
gosh.
my pager?
You know what, Jeannie? I'm sorry. I really have got to run. I'm super late for this dinner.
All
But
right.
I
Is there
listed-
anything? Wait. Is there anything I need to
No,
know?
no, it's all listed right there.
Okay.
You're gonna be great. Okay. Have a
Okay.
great night.
Okay, sign it over because I don't have time. Thank
will.
you.
Bye.
Hey, this is Jeannie Farnham returning the page. Yeah. Which pager? Mrs. H. Hang on a second. Mrs. H. Hang on here. Yeah. Hang on a second. Mrs. H. Okay. Wait. Which pager again? I'm sorry. Okay. What's going on? Okay. She doesn't look right? Okay. What does that mean? Okay, you know what? I'm sorry, you know what? Okay, I will, you know what? Can you just get a blood gas and a chest x-ray and I'll be up there as soon as I can. Okay, thanks. Oh, are you the nurse for Mrs. H who paged me?
Yeah, I just picked her up. I don't really know much about her. All I know is that she's got a really difficult family.
She looks terrible. Can you forego anesthesia? I'm gonna go call the ICU team. I think she's gonna need to go to the ICU.
Okay. All right.
Hey, Jeannie. How are you?
What time is it?
Oh, you know, it's like 7.
Oh,
you know. I hope you had a good night. Did you know, like I hope you weren't too busy or anything.
It wasn't too bad. Mrs. H coded and went to the unit though.
Oh my God, Mrs. H.
Yeah.
We made her a DNI. Like her family came in. It was like super complicated. I mean, what are you talking about? Like,
It says full code on the sign up.
oh my God. I must have forgotten to update it. I am gonna get in so much trouble.
Dramatic fade. So this is a little bit of an exaggeration, but I will tell you that we have had that exact same circumstance happen where code status or something else really important was not updated on sign out, and that key information didn't get passed on. And it can be really hectic when you're an intern and you're cross covering, so it's really important to get this right. So we can learn from lots of other industries that do really important handoffs. You know, in medicine, we often think that what we do is really unique, but there's a lot of other industries that when one shift ends and another begins, if the information is not conveyed right, things go really wrong. Think about air traffic control. Think about NASA. Think about nuclear power plants. And what these industries have learned over a long period of time is that there's some keys to making sure this process goes correctly. Those keys are standardized checklists, having designated times for handoff to occur, having standardized language so everyone knows exactly what's going to come next, and having readbacks where the person getting the information repeats back what they heard to the receiver. And this is how naval aircraft carriers and other industries that are really high pressure make sure that things don't go off the rails. So in healthcare, we have mainly tried to approach handoffs from the point of mnemonics. There has been a race to create the most creative or amazing mnemonic that there is. So you can see handoffs, sign out. My personal favorite, I pass the baton, because it's so incredibly long that no one could ever remember all of the letters, and safe tips. Our nurses did a little bit better. They came up with a 4-letter mnemonic, S-bar, that they've used regularly. But one mnemonic did climb to the top of the doctor mnemonic race, and that was I-PASS. And I-PASS mnemonic was published in 2014 in the New England Journal of Medicine. It started in the pediatric space, and they showed a 30% decrease in preventable adverse events whenever they switched a group of residents to the I-PASS mnemonic. So let's dive in. The ACGME says that no matter where you go, you will have to follow some standardized process, because this is so important for our patients. So it doesn't matter what institution you go to, you'll be following a standardized process. It may be I-PASS, it may be something else, but all of the key content of I-PASS will be in whatever process you're using. So let's learn a little bit more about I-PASS, so you'll be prepared when you show up for internship, and you'll know what information is crucial to convey to your colleague. So we know handoffs, they're dangerous. We know we do them every day, and we know a structured process is important and required. So how do we do them well? So here's I-PASS. The first thing is illness severity of the patient. Are they stable? Are they a watcher? Or are they unstable? The next is a patient summary. Summary statement of the hospital course and an ongoing plan. The next is an action list. So these are the things that the person getting checked out should do overnight. The next is situational awareness and contingency planning. This is knowing what's going on for that patient and what might happen. And finally is synthesis by the receiver. This is the repeat back. Let's dive in a little more. So the first is illness severity. So you're going to put your patient into one of 3 categories: stable, watcher, or unstable. Stable's pretty straightforward. Unstable's pretty straightforward. What's a watcher? So a watcher is anyone where you're leaving thinking, you know, I wouldn't be surprised if tonight this patient got a little sicker, or this patient had a complication, or this patient called the cross-cover team for something. That's a watcher. That person that kind of in your gut you say, yeah, something's just not quite right about them. And a watcher is someone who you want the cross-cover team overnight to go check on that patient during the night, hence the name watcher. So a stable patient would be someone that you don't expect anything bad to go wrong with them, and that you don't need the cross-cover team to go and check on at all unless they're called, and then they would handle it. A watcher, you want them to go check on the patient at least once during the night, and you want them to be aware of some things. And an unstable patient is typically someone you're bringing the cross-cover team to the bedside. They're really sick. Now, also remember that this is going to be very different depending on what service you're on. So if you're in the ICU, a stable patient is going to look very different than a stable patient on the floor. So it depends on what rotation you're on, but that's kind of the general guidance. Early on, I think it's really important to get your upper levels perspective on what is stable, what is a watcher, and what is unstable, until you kind of get this lingo down. So once you've put the illness severity, the next is a patient summary. Now, this is a very brief 1 to 3 sentence summary of why the patient's in the hospital and major hospital events to date. Really important is that it is revised daily. So on the 3rd or 4th day of hospitalization, hopefully you're not saying patient presented with shortness of breath and we don't know why. You're saying patient presented with a pulmonary embolism, or patient presented with a pneumonia, or something like that. You have the diagnosis hopefully by then. It's brief, but it gives pertinent information. Their significant past medical history and any kind of big events that have happened in the hospital and how they're doing. They're getting better, they're getting worse, what's going on. This is not copied from the H&P. So the H&P is generally going to be way too long with way too much information to effectively go into a handoff. And please don't make it a rambling novel of the hospital course. I promise your friend or colleague doesn't want to read through that and won't read through that. So here's a good example. I have a 68-year-old, they have diabetes, COPD, hypertension, and they come in with community-acquired pneumonia and COPD exacerbation that's improving on ceftriaxone and azithro, prednisone, and nebs. So in a concise one sentence, you get a feeling for who that patient is, what their pertinent past medical is, and how they're doing. Contrast that with these bad examples on the same patient. 68-year-old with pneumonia. Okay, that's great, but are they really sick? Are they not sick at all? Are they getting better? Do they have any comorbidities? If you got called on this patient with an elevated blood sugar, you might be caught a little off guard because you didn't know that they had diabetes. Here's the opposite bad example. 68-year-old with type 2 diabetes, COPD, GERD, hyperlipidemia, allergic rhinitis, diverticulosis, recalcitrant ED, and a broken clavicle in '89, came to the ER with 5 days of shortness of breath, cough, sweats, malaise. Felt nauseated after eating chicken wings at his sister's house, spent 15 hours in the ER, and then admitted to our team. Nice guy, but he talks a lot. Right? So you don't want to have that as your example because all of the extra information clouds out really what's pertinent. So concise, to the point. All right, so once you've got the illness severity, the patient summary, the next is the action list. And for every item listed on the action list, it's really important that you have 3 things. So what to do, when to do it, and what to do about it. And this is a really important point. So here's an example. We don't want to say just check hematocrit. What we'd rather say is check a hematocrit at 5 p.m. If it's less than 21, transfuse 2 units of packed red blood cells or 1 unit of packed red blood cells with a goal hematocrit of greater than 21. Again, we don't want to say follow up a CT because we don't know when that CT scan's coming back. We don't know what exactly we're looking for or what to do when it happens. Instead, we would rather say follow up a CT angio at 5 p.m. We're looking for a PE. We think they might have a pulmonary embolus. If they do, I've already checked, they don't have any contraindications to anticoagulation. You can go ahead and start Lovenox, 80 micrograms Q12 hours. So when you put what to do, when to do it, and what to do about it, then your cross-cover colleague is going to be prepared and it's going to really save them a lot of time and help them organize the work that they have to do that night. All right, so illness severity, patient summary, action list. Next is situational awareness and contingency planning. So situational awareness is really quite simply being aware of what's going on around you. So this kayaker is out for a nice time, but is not quite aware of what's looming behind them. We don't want your colleague to be that kayaker. So whenever you have a difficult family or psychosocial situation, or you have nursing, family concerns, you have patient that doesn't want a certain piece of their history shared with anyone else, those are all examples of times where you want to tell your colleague, give them a heads up so that they don't walk into a situation and they're not prepared. Other examples might be a recently completed procedure. So let's say a patient had a subclavian central line placed or removed. They had a left heart cath. Those are all things that you would want the cross-cover team to be aware of. Let's say that the cross-cover team gets a call that a patient's having wrist pain. If they know that that patient had a left heart cath today with a radial access, they're going to be much more attuned to going to see that patient, to checking on that patient, be able to handle that call than if they don't have that piece of information when they get the call. Another thing would be family contact information. So let's say that you spent an hour hunting down the one family member that is the power of attorney and medical decision maker for this patient. please put that person's contact information in the handout, because inevitably something may go wrong overnight, and then that cross-cover team is going to be able to get in touch with that person much, much easier. The other thing that's really important to put in is baseline exam information when it may not be completely otherwise obvious. So this is going to require audience participation. So I need everyone to please close your eyes for a minute, and I want you to imagine a patient with altered mental status. Okay, picture them. Picture them in their head. What is it like when you walk in the room? Okay, now open up your eyes. The great part about this exercise is most of you imagined someone completely different. So some of you imagined a very pleasantly confused person sitting on the edge of the bed. Other people imagined a comatose patient that was in the bed and completely unresponsive to sternal rub. Others imagined someone pretty ornery, not happy with what's going on with the current situation. And inevitably what happens is around the time that the new cross-cover team takes over, the nurses change shifts. And the new nurse goes in to assess the patient, and he or she sees this patient's not acting quite right. And then they call the cross-cover team, and they say, there's something wrong with this patient. If you don't have the baseline exam information, you're not going to know how to handle that call. So here's an example. This patient is awake and alert, but nonverbal and doesn't follow commands. So now, if you get that call that this patient's had a change, and you go in and they're not awake, they're not alert, then you know, hey, something's wrong. But if you go in and they're awake and alert and the nurse is saying they're not following commands, you can reassure them that this is the baseline, this is the way the patient has been. So that piece of information can be really critical. All right, contingency planning. So contingency planning is problem solving before things go wrong. It is, if this happens, then I would do this next. And problem solving for your colleagues so they don't have to reinvent the wheel overnight. So think about what might go wrong. Enlist interventions that have been used on previous times and say, did it work or did it not work? And this is really one that can be quite hard at the beginning, and so I think it can be really effective if you ask your resident early on what to put in this contingency planning space. So here's some examples of contingency planning. Mrs. Jones has frequent panic attacks with chest pain. She had a normal left heart cath yesterday. Symptoms usually resolve with reassurance. So now, when your colleague gets paged that Mrs. Jones is having chest pain, they're going to be much more prepared to answer that call. Here's another one. Mr. Jones has a history of alcohol abuse. If he's hypertensive and tachycardic, consider alcohol withdrawal. The key question to ask yourself here before you leave the day when you're doing your handoff is, what would I not be surprised if this happened overnight? So for Mr. Jones, you've just met him. He's told you that he drinks a case of beer each day, and you're thinking to yourself, yeah, I wouldn't be surprised if he started to have withdrawals in the next day or two. That's the perfect thing to put in the contingency planning. What you think might go wrong and what to do about it if it starts to happen. The last one is synthesis by the receiver, and this is maybe one of the most important ones, but probably one that I get a little bit more pushback on than others. So synthesis by the receiver is an opportunity for the person that's getting the handoff to clarify elements of the handoff, make sure there's a really good understanding, and have an active role in the handoff process. So in other words, what we don't want is the person giving the handoff to talk the entire time and the other person sitting on the other side just nodding their head but never says anything at all. The receiver, the person getting the handoff, should really repeat back the key phrases of information so that the person giving the handoff knows that they were heard. And also there should be an opportunity to ask any clarifying questions. And at this point in time you might be saying to yourself, is that really necessary? I mean, we're two smart people. I'm talking, they're listening. Shouldn't that be enough? And I say, well, can you think of any other situation in your life that was so vitally important that you communicated information to someone else, and if they didn't repeat that information back, you would be furious. And you would say, I knew they were not going to hear me. Even though I talked directly to them, I knew that it was not going to, they didn't know what I was saying because they didn't repeat it back and I didn't hear them. And that's why they got my order wrong. And I knew it, so why didn't they repeat it back? So we expect this, right? When you go through the drive-through, you expect to get a repeat back of your order. So I would just ask you, if it's standard of care for your Whopper, can we make it standard of care for your patient? All right. Now, this doesn't have to be you repeating back every single thing that you just heard. It's just the really key pieces of information like, okay, got it. So this guy's here with pneumonia and he's DNR. It's already been over with the family. Great. It's not the reading back of the entire handoff. And for a very simple patient, you know, Mrs. Smith has been here for 73 days and she's still awaiting nursing home placement. That time, a head shake might be okay. But most of the time, we're going to need to repeat back at least some small piece of information, or ask a clarifying question, something that, did I hear this right, or have we? What do I do if this situation comes up? All right. The other thing is that if you're getting handoff and you see that there is an action item that they didn't list all three things, maybe they just put follow-up B and P, that's the opportunity for the person getting handoff to say, when do I do this and what are you looking for? What have you talked about that we should be thinking about and doing about it when we get it back? And if the contingency planning and situational awareness spaces are completely blank, this is a great time to say, do you think anything's going to go wrong with this patient tonight? And that can be really helpful if they say, no, not at all. Or they say, oh yeah, no, I think that you'll get called about their pain. Then you can say, great, what's worked for pain or what hasn't worked? And that can be really helpful information. So IPASS, illness severity, patient summary, action list, situational awareness and contingency planning, and synthesis by receiver. And even if your residency doesn't use that exact mnemonic, I promise all of those components are going to be in whatever standardized process they have. So let's wrap up with some keys to success and some pitfalls to avoid. So the patient summary really needs to be brief. It's not long, it's not exhaustive, and it's just key information. And a pearl for this is to write that patient summary and then bring it to your resident and say, what else would you put for this patient or what would you take out? And you'll see them cross things out or say to add something else. And that's really helpful in the first couple months of internship. Update that patient summary daily. So please don't find yourself 1 week into the hospitalization with the same patient summary as you had the first day. This should be updated as the patient's hospitalization progresses. With your action items, be very specific. You need 3 things: what to do it, when to do it, and what to do about it. And spend time thinking, what should I put in that situational awareness or contingency planning, and what to delete? Because hopefully on day 10 of the hospitalization, we don't have in there anymore, be aware for alcohol withdrawal, because that should have happened already. And if it hadn't happened by day 10, it can be deleted so that it doesn't clutter up the handoff. Read back important information. Just please remember your patient is more important than a Whopper. And so just read back some of that information. Before you leave for the day and do your handoff, think, what's most likely to go wrong for this patient tonight? What would I not be surprised to hear about in the morning? And if there was a cross-cover issue before, how is it fixed? It could happen again, so make sure to put that in your handoff. So that concludes the talk on handoffs. I hope you've enjoyed this and it's given you a little bit of preparation to handle that first page that you get in those first couple months on internship when you're taking care of patients overnight. Have a good day. Bye now.